there's a legitimate question there about, does it tell us that, we are detecting more cases because we are looking for them, or is it that the cases are actually rising organically on the ground? The evidence in our case appears to be that the cases are increasing on the ground. And we know that because every time we go out to conduct testing, especially through the routine surveillance group, which is people who are coming into health centers with symptoms and then are being tested and found positive, the proportion for every 100 of them we do, the number of them that we find is going up. Right now, for the last 10 days, the average of the number of people of every 100 we are finding is about 11. That number was about 4 all the way back in April. So we know that the actual risk on the ground is increasing. And what that means for us as individuals is that we have to understand what exactly is being said when we are told that, we are going to live with the virus. It does not mean that the risk is reduced, because the data shows that the risk is actually increasing. The probability that you're going to come to someone who has it and then get it is increasing as a fact. The question is, are we able to, at the individual level and at the societal level, implement enough interventions that make it so that we as individuals, by wearing masks, by washing our hands, by going by social distancing, can reduce our risk of passing on or getting the virus in order to slow down the rate? And can we have social public health interventions that make it so that we are not creating opportunities for those transmissions at mass gathering events like stadiums or religious worship centers? Those are things we need to be aware of. Those are things that have to be reduced so that we can manage the increasing risk. That's what we're talking about when we say we are living with the virus. So it's really important that people understand that there has not been a period in this COVID-19 story in Ghana so far, this is day 99, where the risk has been higher. So people need to really be very much aware and very much conscious about the measures they are taking for themselves. But authorities also have to be candid about the fact that the risks are higher. So some of the measures that reduce the in-person contacts, including things like worship centers and maybe even even the educational institutions, all those things would have to change eventually, while to be reviewed, if we are going to reduce the community risks associated.
Well, I'll come back to the review, but the WHO had earlier said that we in Africa are the next epicenter for the outbreak. Based on the numbers, can we say that it has started? Africa is now seeing its cases, actually.
Yeah, I think if you look at the first 100 days, or let's say first 110 days of the epidemic in Africa, from day 1 to day 98, we detected 100,000 cases. The next 100,000 cases were detected over just 18 days. So we know that the rate at which we are picking up infections is growing. Some countries obviously are having a very serious challenge. I would say South Africa is probably the leading example. For the last 7 days, every day they've detected about 3,000 new cases. That's a trajectory that is not sustainable for their healthcare system or for their public health system. And what we are picking up in Ghana here ourselves is also pretty alarming, because what we are seeing is that since June 1 to June 18, our cases have gone up about 52%. So we know that the pace is picking up, and that our rate of increase is actually higher than in Latin America right now, or in Europe, or in North America. So we know that, Latin America apart from Brazil, but we know that there's obviously an emerging concern in our parts of the world, and the way to deal with it, in my opinion, right now is for us to be candid about that fact, for there to be more regional cooperation, especially when it comes to procurement of things like reagents for testing or PPE for healthcare workers, because there's no reality where individual African countries tackle this effectively without networking their resources and their skill sets.
And having said that, if we're getting into the point where we should be worried, should we be looking at some further reviews? If you recall, we had a partial lockdown in place. It was lifted. Now, it looks like we are back to normal life. If you go to our markets, you'll be very worried. If you go to our public areas, people are gathering. Should we be looking at that way and perhaps maybe some restrictions being put in place?
I think like it's just kind of exactly what I was saying earlier, right? So that there are things that we as individuals can do to reduce our risks, but there are certain social spaces that only the public authorities have the ability to control what happens there. Those are the things we have to review. And I would agree with the issue of the lockdowns, because factually, the point of a lockdown is to reduce the number of in-person contacts as a means of slowing down the rate of spread. That lets you catch up on testing. That lets you catch up on contact tracing. And those are the things you need to have in place to manage the actual risks of the spread. So there's no scenario where we can say that we are behind the pace for testing, we are behind the pace for tracing, but we can continue in our current state as the virus spreads, and we're going to have good outcomes. That's just not factually consistent. It's not logically consistent. It doesn't follow the public health realities. So it will be necessary ultimately for us to reconsider some of those social restrictions. I think definitely we should be reversing at least the easing of restrictions on things like funerals. I think we should go back to the 25 cap, because obviously the lifting to 100, we know that that is being abused, willy-nilly in a lot of parts of Accra and other parts of the country. So we need to review those things and look at some of the localized lockdowns. That's why public health experts have been asking for disaggregated data. We don't want to look, it's good to know the national numbers, but it's important for us to know the district by district distributions by age, by sex, by occupational group, by locality. So we understand exactly what's happening at the very micro level in the country. So we can better target those lockdowns and social restrictions, so we reduce the overall disruption to social life. But if we don't have that data and we're not working to disaggregate that data, then we are compelled to do more sweeping kinds of policies that do have, more broader social disruptive consequences than they might otherwise if we had more minute data.
Well, I recall speaking to a biostatistician who says that the data that we have currently cannot assist government to make the decisions that it needs to make. There's also been a suggestion that we need to change the way we are approaching this. And it looks like government has been doing the same things it was doing when we had one case, when we had two cases, when we had three cases. There has been no change. What significant changes do you expect to see? And do you see any change at all in the way we are approaching this?
I mean, I think there were definitely some innovations that came up through the public health workforce themselves and through our diagnostic teams that have been helpful. Pool testing allowed us to get around, for a time, limitations on testing, and that therefore supported more rapid contact tracing. That was a good innovation. But we know that some districts, for example, decided to hold on to the contact tracers they had from the lockdown period, so that they would have the scalability as the epidemic expanded. Those are good innovations, but those are things that should be happening anyway, and that should be happening everywhere. And our testing levels, especially, is a thing that we have to scale up. So there are things that we've seen so far that have been good innovations, but the reality is that on the whole, we appear to be treating the response as a checklist. So we have to do some amount of contact tracing, some amount of testing, but we are not treating it as a dynamic system where it's more like a feedback loop, where if you start to pick up, outcomes that are not consistent with the policy measures you put in place, so a rise in cases despite the fact that you are easing restrictions, or to put it better, a rise in case because you're increasing restrictions, you should be able, you are reducing restrictions, you should be responding to that, and therefore just, putting in place policies that you've taken out at the time where you had less of a problem. if we don't have that kind of responsiveness in the system, then that's a problem. Because the key feature of pandemic response or epidemic response is flexibility, is dynamic thinking. So if we are setting it up as a sequence of events that have to happen rather than a feedback loop of events and outcomes, then we're not doing exactly what we should be doing here.
And that's that point that some people have been making, that if you look at our, there seems not to be any room for a review or an assessment at every point in time. We've done this. How is it going? Then we'll change. It looks like we keep relaxing more and more when the data is saying lock up or close up, but we are relaxing. What do you think needs to change immediately?
I think you put it very well. I think what has to change is our openness to review, the transparency about the methodology, variables, and findings of those reviews, and the communication of them to the public in a way that is candid, consistent with the facts, and that inspires public trust and confidence in their response. If we tell ourselves that we're not going to be doing any kind of detailed, systematic, consistent review that again responds to what the data is showing us, and what the data, and that being that community spread is ongoing, the rate of spread is increasing, then we're not going to be doing the things we need to do to make sure that we can get our hands around this situation. And like with any epidemic of this nature, the growth is exponential. There's a threshold beyond which a lot of the kinds of measures that a country like Ghana can do will not be feasible anymore. There's a point at which you have too many cases and contacts to trace. There's a point at which you have too many new infections to test. And if we are not open to responding to what the data is showing us about how quickly we are approaching those thresholds, then obviously you will hit those thresholds and the consequences will be borne out. So it's important for us, absolutely right now at least, to pull back, do an objective, honest, candid data review, and concede that we do have rising community spread. We do have greater risk in the communities, and that is inconsistent with a one-directional course of easing of restrictions.
Well, having said that, have we gotten to that point yet? Because we are seeing 97 health personnel contracting COVID-19 is one of the headlines in the Chronicle this morning. We are hearing about the NHIS recording some drastic cases. There have been calls for the close down of the NHIA. We are hearing some hospitals dedicated to the treatment of COVID-19 saying, we are full, our beds are full up. We are struggling. We don't have PPEs. We are unable to keep up. Are we getting to that point already where we may be so overwhelmed, we would have nothing to do? We would not be able to do anything?
I think some of those reports coming out are extremely concerning because even though we don't have specific data on number of ICU, at least it's not public data on ICU beds and rate of hospitalization, rate of discharge, which are the things we usually measure those empirically. The anecdotal evidence directly from healthcare workers, from the Ghana Medical Association, regional health directorates, district health directorates, all consistently seems to say that if we are not at that point, then we are very close. And what that suggests, especially when you start seeing large amounts of healthcare workers get infected, is that the time you have also then is being reduced by a second factor. Because as more and more people drop out of the healthcare workforce, as more and more facilities go offline or become full, the options for treatment for newly infected cases, which are increasing, become limited. And so the quality of outcomes you start getting in terms of rate of recovery or time to recovery and the likelihood of people dying, all those things start trending in the wrong direction. So I can't make a definitive statement that we are at that point because there's no public data that allows us to do that. But we are hearing from healthcare workers, the frontliners themselves, in many different fora, as individuals, as facilities, and also as they're at the professional organizational level, that there is a real cause for concern about this issue?
Well, a definite question. Two places. The National Health Insurance Authority head office recorded 7 cases. Parliament has recorded some cases where they have asked some parliamentarians to quarantine themselves. The majority leaders say they are not doing that. Those 2 places, the calls are for the close down of those offices. Do you agree?
I think with Parliament especially, if you have a scenario where you have people who are infected and who, despite their knowledge of their infection or high risk of exposure, are refusing to isolate, then the managers of Parliament have to take some very serious decisions. Many of the members there fall into a high risk age group. We know that, you know, the risk of transmission in a chamber like theirs where you have circulated air is extremely high if there's a lot of people who have it. Even if you have 10 out of the 275 who have it, the risk of them or others contracting it is pretty high. We saw that play out in the Tama Fish Factory situation, which, you know, similar such settings, air-conditioned environment, recirculating air. We need that's one of the places where they really need to take a look at that, because if they cannot get people to comply by their own volition, then there have to be organizational level interventions, which can include going to virtual settings or suspending settings until they have a handle in terms of an additional round of testing if the people who are infected have still been coming in. Because if you are positive at the time that person was tested and that person is still coming in, so if you're negative at the time that person was infected and that person is still coming in, you're interacting, you could now be positive. So there should be another round of testing to verify all those things and to do subsequent contact tracing from those new cases. And it makes sense until such a time they do that, that life should not be continuing as normal there. It should not. Visitors should not be going to Parliament. They should be making sure that even among parliamentary staff, it's only the most essential. And absolutely, as a first option, they have to make sure that they are compelling the infected persons to isolate. And if they can't do that, then they have to make sure that they close down, at least close their doors or reduce the operation at such a time as they can get a sense of the consequences. At the NHIA, I've heard reports about how the staff themselves, about how the senior staff, 7 senior staff have been infected in addition to the CEO. And the suggestion there is that they are going to a skeleton staff as at now, that they are going to have only essential workers. They've asked high-risk employees to go home, and that they've closed off the facility to visitors. Those are good first steps, but obviously employees there also have the right to be heard out if they know that the environment is high risk, and especially if it hasn't been fumigated since the time that the infected co-workers were last there. Then there's a legitimate concern for occupational safety, which would say that at least, or maybe over the weekend when the NHI usually isn't occupied, the building isn't occupied, that some amount of fumigation should go on there at the very least. And if that's the kind of thing that's not happening, then the goal should be trying to reduce the actual number of people who come to that facility to the very barest minimum, and compelling all staff of the NHIA to remain in quarantine at home until such a time as they can all be tested. Because that's an important aspect of the response as well. Because by virtue of the fact that they share common spaces at the building, common staircases, common elevators, common lunch areas, the touching similar handles, it's important for us to make sure that everybody is tested there, given the lag between, I guess more specifically, the lack of specificity of the lag between when the infections actually happened and when they were detected, and how long they've been moving around the facility with the virus. So all those things have to be taken under consideration.